Well, I'm just going to take the audience quickly through the Ally system. Carl is a potential new user, is that correct? Audrey is a tried and true FLACS believer, bimanual surgeon extraordinaire, and user of multiple technologies over the years, and user of LENSAR. And Kendall, she can do whatever she wants. So we're trying to entice her into getting on board with this new technology, right, Kendall?
Exactly.
And we want
I
want her level-minded perspective too, because we're all bought in, and Kendall has the clear mind here. And Harvey, we know, has done most of the pioneering work with LENSAR OUS and has been instrumental. So the Ally system, our Femto phaco device unit in combination, is really right on the horizon. It's submitted for FDA as of recently, and the typical time frame of that could be somewhere around 6 months, 5 to 6 months. So fingers crossed, we have a very competent team that has brought this through completion. So we're really hopeful to see this in Q3, 4, hopefully, by its time it's in our hands. Amazingly fast and efficient machine, as we've described here earlier in the panel and session. The 6 cameras is a key feature. This is going to save a lot of time. The fact that it is that it's just going to happen so quickly, as was mentioned earlier, once you get into the mundane world of cataract surgery and you're trying to knock out 20 or 30 cases in a block, these little moments add up. I've seen surgeons looking at their phone during imaging. I've seen them changing the radio station. I've seen them having conversations. So it's nice to have this imaging happen simultaneously, and it's just going to shave a big chunk of time. The sad part is I recognize that image on the right enough to know that that's a pig eye. Does anybody else work with pig eyes enough to recognize that as a pig eye? So you can see the treatment time is much faster. This is the current system, Gen 1 on the left, Ally on the right. And for those of you on any laser platform have had issues with capsulotomies, which is always the big elephant in the room on any laser platform, is the capsulotomy. And we've all seen anterior tears, we've all seen little wisps, we've all seen little edges and things. A lot of it has to do with the time it takes to do the capsulotomy and micro movements of the eye during that time. So it's only natural to think that when we speed up the time of the capsulotomy, that the capsulotomy is going to be better. There's going to be less irregularities at the edge. There'll be less patient movement. So that'll be exciting. So much faster treatment. With regards to positioning in the operating room, there's all different sizes of operating rooms. This device has been designed to be pretty universal, so the bed can come in from any direction, and there's going to be a little like QR code that you're going to use to angle it at the direction you come in with the patient. Your staff will do it, and that'll let the machine know at what angle the bed is coming in at. It'll just take a second. And then iris registration will take over for the remaining 10 to 15 or up to 20 degrees of cyclorotation. We're not going to count on the cyclorotation to account for 240 degrees of cyclorotation. So we have to have an initial metric to align the bed to the laser initially, grossly, and then the registration will kick in from there. But what you could also do, if you know you're going to come in the same direction every time, there'll be a way to bypass that most likely, so it becomes very automatic, because once you get it set up in your room, you're mostly going to be coming in from the same direction each time. But it is amenable to any positioning that you'd like it to have to these different angles approached. And like I said, it's a very small footprint, the size of a phaco machine, and it can be wheeled around to different positions in the OR if it's moved around from left eyes to right eyes. Just taking you through, you guys have seen this ad infinitum today about the different fragmentation patterns. We're probably going to broaden these categories to be more specific to different grade nucleus and size. And we just went through the early integration part, and that will be the Pharos that you see there. Very good integration, and everything will be done sterilely. And so Harvey, I think we should take this opportunity to, you have done the very first cases in the world of the actual device, the new device in its final form, the same one that we just submitted to the FDA here. And tell us a little bit about what happened, because you're on the front line here with this.
Yeah, thanks, Rob, for that nice introduction. And I'm
I regret not being there physically to make this presentation, but I'll do my best. So I think the best way to demonstrate the features of the Ally system is to show a side-by-side comparison versus the original LENSAR unit. And here you can see on the left the Ally system, and on the right videos from the LENSAR system. And one of the key changes will be the patient comes under the Ally system already prepped, draped, and ready for sterile surgery. Whereas with the LENSAR system, the patients come in and we do the procedure, the laser procedure, in a not sterile fashion. You can see here on the left the QR code registration, which is done by the nurse, and this tells the computer how you have oriented the patient. So when you come into the room, the surgeon then gowns and puts on sterile gloves. Whereas with the original laser system, we're doing this in a non-sterile fashion. So you can see here that at this point, we're a little bit ahead in this real-time comparison because we don't have to put on the gown and the gloves. So we're already starting to do the docking. So we're a little ahead with the original LENSAR system. But you can see that this small lead is basically obliterated, and using the Ally system quickly allows you to overtake the LENSAR system. We found that the suctioning using the Ally system is a lot more robust. You're able to latch onto that eye much more firmly and quickly. And with the small Asian eyes that we deal with, we're able to do the Femto system even with the original large round PID. The suction enables us to do even difficult eyes. And we really love the 6 cameras. This is a game changer. It quickly scans the anterior segment. It looks like the processing time is also faster. And certainly we see faster laser firing time. So you can see that in the Ally system, at this point, we're already way ahead. With the original LENSAR system, we're just starting to do the scanning of the anterior segment. But with the Ally system, we're basically finished with the scanning and the planning, and we're now proceeding with the treatment. We also noticed that the firing time is a lot faster, so you can see here that the Ally system quickly does the laser anterior capsulotomy. The fragmentation pattern is also very quick. In the Philippines, we have some of the hardest cataracts imaginable, and we tend to use this pie cut pattern fragmentation. But we've also tried to use other patterns like the cube pattern, and we found that all of them are very useful in the later nuclear disassembly. We also find that this color image, the down the pipe color image is very nice because it allows the surgeon to better monitor the progress of the surgery. And you can see here the quick creation of the clear corneal incision, the main incision. We just do it in a single pass, followed by the paracentesis incision, also done in a single pass. And before you know it, the laser portion is over. And this is the maybe the biggest shock is that after you've done the laser portion, you're waiting for the nurses and staff to move the patient to the phaco machine, but then you realize you're on deck. You have to do the next step. So here we move out the laser head, and then we move in the surgical microscope. And for eyes with large palpebral fissures, we've already applied the lid speculum. So we just wash further with the betadine, and then we can proceed to open up the wounds. We found that the incisions made by the Ally are much more easy to open, whether it's the paracentesis or the clear corneal incision. So opening these wounds takes up less effort. The clear corneal incisions are generally effortless, and we're able to proceed with this surgery. Back here with the LENSAR system, we actually take about 6 to 7 minutes to transfer the patient from the LENSAR, the Femto unit, to the area where we're going to do the phacoemulsification. So if you do your cases in about 6-7 minutes, that's already the amount of time it takes you to do the phacoemulsification. So using the original laser, by the time you're ready to do the start to do the phaco procedure, if you were using the ally unit, you'd probably already be finished doing the whole procedure. So overall, we've had excellent outcomes. We've done 20 cases so far, all of them successfully, no complications, and we look forward to using more and more of the ally system in our practice.
So one question, Harvey, that comes to mind that's very different for us is this concept of doing a sterile femtosecond laser. And is that any harder with the drape over the eye and the speculum, or if you don't use a speculum, if the drape is not cut properly, is it harder to dock it on the eye? Any pearls on that yet?
So if your patient has a large palpebral fissure, it's best to apply a lid speculum, and that clears away the drapes, and that greatly facilitates the suctioning and completion of the laser procedure. So if your patients don't have a large palpebral fissure, then you may want to use the elliptical PID, but the suction itself is a lot stronger and a lot better than with the original laser system. So we were able to do eyes with small palpebral fissures just applying the original round PID. And we were able to do this successfully. Sometimes you may take 1 or 2 attempts, but you're able to complete it.
Excellent, excellent, fantastic. So panel, Kendall, let's start with you. A little different. Is there anything super compelling to you? You've used a lot of femto platforms. What do you envision for this? Advantages, disadvantages, revolutionary? What do you think?
Sure. I can't wait to get my hands on this. I would love to have it today, and I have worked with all the other laser platforms. You know, I think anytime we have a new piece of technology, we kind of evaluate it with respect to 2 things, safety and outcomes. And I think this could potentially allow us to put less energy into the eye. It's a very safe procedure. As far as refractive outcomes, I love the ability to really hone in on that astigmatism correction. So I think that's fantastic. You know, I think what's held back femtosecond laser technology for cataract surgery over the past 10 years is that cost-benefit ratio. And so there'll need to be more robust studies, you know, because people are going to be investing in this. I think it's fantastic. I love the small footprint, like Carl was saying. I think that's going to be huge, and I think it's just amazing technology, and I'm thankful to have it. And we'll see how the cost-benefit ratio kind of weighs out over time.
Do you think that there are going to be surgeons that feel that their current generation laser, whether it's a LENSAR or LensX or Catalyst, whatever, is like, this is going to compel them to be like, okay, I needed, like just like with phaco machines, after 6-7 years, they come out with a new one, you get a new one. Do you think that there's a story there, or that are these Gen 1 machines adequate enough?
Well, I mean, they're going to be getting rid of their phaco machine. They're going to be getting rid of their femto, or you know, maybe they didn't have a femto, or they already decided they didn't want to use their femto anymore. So we're going to be, you know, putting forth a story to say, well, you know, this is very efficient. It's going to give better outcomes, and you know, it does all of these things. But of course, everyone has their phaco machine already, so we'd be replacing that for something hopefully better, more efficient, provides better refractive outcomes. So I think it does have huge potential, and we'll see how things weigh out with the logistics and finances of things.
Right.
But great potential technology.
Yes.
We recognize that the phaco machine in particular is one of those items that, you know, it's sort of practice and something that you're very used to. And so this is probably the hardest thing. I think the barrier of entry from an adoption perspective, you know, that we're gonna be doing obviously a lot of work with is the phaco device. And so the reality is that if you're not ready to fully embrace the phaco device on every case conceptually, you can still do a full-on sterile procedure with this. Have it sitting right next to your phaco machine, because now you can put this anywhere you want, and move and use the phaco machine that you're most comfortable with, and sort of crawl, walk, run into this. And truth be told is that, because Ertley didn't get their Pharos approved, the Pharos isn't approved yet here in the US, we're bifurcating the filing anyways. And so we've already submitted the 510K and it's under substantive review for the Femto portion of the device. The Phaco now is included as part of that device, and it will just be disabled when you get your device, and then it'll be enabled after we file. So it gives you a chance to really, prove out the efficiencies and the speed, and get your OR set up, and then sort of migrate over.
But Nick, I think to your point, people are going to be pleasantly surprised. Kevin made some really great comments. Ortley came out in 2004. I just happened to be lucky sitting next to this booth when I was talking for Wavelight years and years ago. It was like 2004, 2005. So this company's been around, and just like Kevin says, what do the Swiss do? They make things smaller, and I kept looking at this and saying, how do you guys make that thing so small? Right. And so it was small back then, and the footprint was small. And I think everybody, I've used it a lot in wet labs and stuff. It's a really nice phaco machine. But the most important thing, and I just met the CFO, so don't shoot me when I say this. Stephen Dell and I talked about something. You're going to have everything in one box. So theoretically, you're not going to be paying maintenance fees on all these different parts of your practice. And I think that's another big plus when we start talking about dealing with one company with regards to our phaco packs and everything else included.
Well, I appreciate that.
It's also the efficiency. If you're currently doing, I think one of the main barriers has been that surgeons say, oh, well, it's so inefficient because I have to do less cases, right? Because there's the time that it takes to do the femto. Well, now, first of all, the femto portion is much, much faster. Second of all, it's integrated. And so like right now, I love the cataract densitometry, and depending on that, then I have different phaco settings for my current phaco machine. Well, that'll be automatic, right? And just the efficiency and the throughput and being able to then do more cases, there's not going to be that barrier, I'd say, I have to do less cases, and, therefore, even though the revenue goes up, maybe because I'm doing some refractive, I think it'll make more economic sense also. And I think as people have, your phaco machines have a certain lifetime, right? And now different companies are coming up with next generation time for a lot of the companies for new phaco machines. And so I think it's about the right time that people are going to start to be looking at, I have to replace my whatever you have right now, right? And so I think it's really good timing, and I think it's very exciting.
But to your case in point, Denise and I had this conversation in December. We're working smarter and not harder. And so my point is my partner will do 30 cases in a day and make $350 in his pocket. So he's taking home $9,000, $10,000. Well, I'll do 10 cases in a day, and I'm taking home $20,000. So one of the things, people say, how do you do so many phacos, and why you have such a large percentage in your practice? Everybody is a femtosecond and a premium until they prove to me otherwise. They don't have the anatomy, they don't have the money. So we initially start talking to everybody about, femto, phaco, premium IOLs, and we don't even talk about the other stuff until they say, they got an epiretinal membrane, they got a bad dry eye, they got something else that's going to keep us from doing that.
Well, Audrey does femto on everybody, so she's been kind of revolutionary and did a cost-effective way of just balancing it out, and they might not all get astigmatism correction, but they all get fragmentation, and that's a real big plus for this technology. I think that we're going to see more surgeons go to that.
I would love to do that. I would love.
Shaq's
it's
done it, you've done it forever.
Really correct astigmatism in everybody.
Well, it's not. If I'm going to correct astigmatism, then I'm going to charge for it. Okay, because then there's that expectation you're setting up for a refractive patient. But basically, my patients are either like 70% are getting some kind of premium something, right? The others, a lot of them, they have, I don't know, Marfans, they're 90 years old and they have like 3 zonules to their name. They have a super, super dense hard cataract. They have, something else going on. They have pseudoexfoliation, whatever it is. And those are the patients, in a sense, who most need the technology, because your capsulotomy on a dense white cataract or a black cataract, that is made easy. You can take the stress out. You don't have to worry about your Argentinian flag sign, because it really doesn't happen. And that's where the increased safety in terms of these really challenging cases, you just make it so easy.
Harvey, the speed factor of the procedure, I mean, you were doing a very complex frag pattern. You had a complex frag pattern and all the incisions. And, it's so much faster. I mean, what was your impression after the first couple cases? Harvey, did you think it was working, or it wasn't working because it was happening so fast?
Yeah, I thought something went wrong with the machine because everything was under 2 minutes. So I thought we forgot to do some step, but actually it had completed everything. So it's blazing fast. Congratulations. Overall, in the 20 cases we've done, all of the capsulotomies were free-floating, and we tested different sizes of the toric alignment nubs, and we didn't have a single damage to the anterior capsule. So all of the capsules were intact at the end of the surgery, and we did some very, very hard cataracts.
And how about the design a little bit? Can you speak to the joystick on top of the machine versus down low? Did that take some getting used to? Was it ergonomically friendly?
For me, it was very easy to reach up. So instead of being at like belly button height, now it's at shoulder height. And I didn't have any problems adapting to it. It seemed to be more responsive, the joystick. And I had my wife do a couple of cases, and she didn't have any complaints.
Well, my wife's a gynecologist. So I'm going to have her do a couple of cases, see what she thinks.
The LENSAR in the room, it still took 7 minutes longer. Imagine if you had the laser outside the OR. It's going to even take more time. So this is really going to save a lot of time for most of those practices that have the laser outside the OR.
You make a good point, because right now many of us are having a femtosecond laser feed 2 or 3 ORs. Mm-hmm. So if you were to put this device in just the femto room, then you're not really doing the cataract surgery there. You're going to move the patient. So that it might, like Nick was saying, there might be a bridge that we do here while we're waiting for the Ally phaco part to be approved, right, where maybe it just does at first replaces our current femtosecond, our current LENSAR unit, where it stood as a starting point. Then once the phaco comes, then you put one in the OR, maybe keep one outside. But eventually, I can't imagine we're not going to want to your point, Kendall, find a cost-effective way to have access to this in all of our operating rooms, just like we have a phaco in all operating rooms. So if Nick and his team can figure out a way to make this viable, because we all go out and buy 2 or 3 phaco machines every 7 years or 6 years. So I know this might be a little more expensive, but that's going to be one challenge, but that ultimately would be, in the big picture, the most beneficial, I think, to throughput and utilization of the technology is to have it in all the rooms. Harvey, would you agree that now that you've used it, this is something you're going to want in each OR if you ran multiple ORs?
Yes, it's very flexible, and in the Philippines, it's largely pay out of pocket, so this system gives you great flexibility. If a patient wants just the phaco, then you go to the same machine and you just do the phaco part, and if it's femto phaco, then you do both in the same machine. So it does create less confusion for the staff, and the most important thing is the outcomes are very good, and I think at the end of the day, that's what matters to all of us.
That's a good point. And the other way that I'm considering about doing it is leaving my current LENSAR where it is in the femto room, adding this into one of the ORs and starting to have the current LENSAR feed 2 ORs and have the new machine just be isolated in the one, and that way I can kind of get my feet wet with doing it sterilely and just use my Stellaris until the Pharos is approved. So I think we'll all invent our ways to integrate this, but it's super exciting.
I've got a question, which is, are you still, and maybe Harvey can answer this, do you still have the ability on the fly to change your capsulotomy size? Say there's a denser nucleus, and you know how now you can edit the plan? You can still do that, and then you can still actually move the capsulotomy, like if you have Marfan's case or something like that, or a traumatic cataract and you want to physically move it, you can still do that on the fly, yeah? Okay.
Yes, that's one of the great features of LENSAR. You can adjust it on the fly.
Any issues with the timing? Any pearls on the timing of the priming of the calibrating the laser case for the Femto, and then also priming the tubing? Did you have to do a lot of training for your staff, or do you have two people working on it at the same time, one on the Femto side, one on the phaco side, or is it one person doing the planning and the phaco priming?
Yeah, so we have one nurse doing the planning, and then another nurse doing the planning. So two nurses, but no issues at all. And it probably only took one case for our talented OR team to transition from the original LENSAR system to the Ally system.
And you had not used the Faro system prior, or the Earthly? This was your first exposure, all in one shot?
Before we did this Ally series, we actually used the Faro system in preparation. But we do have one satellite clinic where we have used the Cataract 3 for many years now. And we found that as the previous speakers have said, the Earthly phaco machines are very robust. They can attack the hardest cataracts imaginable. We don't have any significant service issues for many years now, and I would not hesitate to use a Earthly machine.
Was your staff pleased with it, Harvey? Did they any pushback or anything that they got frustrated with that seemed challenging to them?
I think the main one was right now pulling back the laser head is still a manual process.
Okay, I think what Harvey's talking about is the laser arm moves out for the laser treatment, and then when you bring in the microscope, it retracts back. So that's just something the staff is going to have to get used to, the mechanism of sliding it in and out of the field sterilely if it's the same person that is scrubbed in. Harvey, thank you for your great work and for being here. Panel, thank you all. Thanks to LENSAR for an incredible piece of technology and a really great time to celebrate for this company.